This is Sandeep Gidvani. I'm giving a talk today on surgical coding and documentation with respect to thoracic and lumbar procedures. This talk is part of the resident and fellow education symposium. So as far as disclosures for this talk, I have no relevant financial disclosures. I will say that my practice is primarily a degenerative spine practice, so that tends to be the focus of what I'm going to cover. The early part of this talk in particular is personal opinion. And my goal here is to simply present you with an overview of surgical coding. It's certainly difficult to identify every single code that's needed within spine surgery, but I wanted to sort of give you an understanding of what the basic principles are so you can practice this on your own. So the objectives here today are to review surgical documentation relevance and help, in fact, improve your surgical decision-making in this process. I want to make sure that you know how to support your surgical requests from insurance companies and familiarize yourselves with coding for common procedures. And finally, the goal is to give you sort of a working base to, again, practice this as you go through training. So this is probably our perspective, most of our perspectives to documentation. Why do we have to do this kind of thing? It's repetitive, it's cumbersome, it soaks up a bunch of our time and takes away from what we really need to do. But I think that there's a different perspective to be had here. I think it certainly has importance, and if you think about documentation from the perspective of how do I obtain authorization in a seamless way, there are critical elements to focus on. In-office billing is equally important to your practice of spine surgery, especially when you think about this from a business standpoint. If you follow a template, it often makes the pain that's associated with documentation a lot less. And I would pay attention as we go through this to key descriptors in these sections of your report. So this is a slide that I borrowed from another talk I gave about community positions, in particular in private practice, and understanding the business model. Remember that seeing patients in clinic and billing for these visits is an important part of your income generation. And in turn, this is what leads to the ability to do surgery. So it plays a significant role there. So if we start with the history of present illness, oftentimes you're talking about an axial region of pain and the radicular component that's associated with it, such as pain, numbness, tingling, or weakness. It's certainly nice when the patient presents with a dermatomal distribution of pain, but oftentimes they don't. And in those situations, it's important to simply describe where they're complaining of pain, numbness, or tingling. I also include things like the duration, the character, severity, and frequency of their symptoms. I talk about what makes it worse and what makes it better. History of trauma might seem irrelevant in some cases, but I always ask this question. And the reason the situation where it becomes important is in particular if the patient was involved in a motor vehicle accident. At a later date, you might find that yourself is deposed and they ask you questions about what was the history of this person's onset. And if there was a trauma involved, such as an accident, it certainly shows your professionalism that you investigated it, and it makes your life a little bit easier. With respect to lumbar surgeries in particular, or even thoracic surgeries and in particular fusions, most insurance companies look at psychological history and they want to ensure that the patient is of sound and stable mind, because there's literature that demonstrates that those with a psychological history that's not well controlled don't do as well as far as outcomes. So you can ask about this, and certainly if they have a component of depression or bipolar disease, you want to make sure that you document stability if they're on medications, and whether or not they consult with a psychologist or psychiatrist. The other important parameter is smoking. So do they smoke currently? And if they've stopped, how long have they stopped for? If they were smoking up until recently, what are their plans to quit? Who have they utilized to be able to cease smoking? Because most companies want to ensure that they are not smoking before they'll authorize a fusion. As we know, this impacts the rate of non-union and revision procedures. I always talk about the treatment to date. So, certainly with respect to spine issues or diagnoses, you want to talk about their participation in physical therapy, and 6 weeks is typically the cutoff to move forward to the next step, whether or not that's advanced imaging such as an MRI or CT myelogram, or even talking about surgical intervention. If they have had injections or epidural injections, I talk about the number of injections they've had and the effect. The effect is mostly from a diagnostic standpoint, to demonstrate concordant relief and whether or not it was temporary. Physician-directed exercise is a sort of terminology that I learned from talking to different peer reviewers and being a peer reviewer myself. If the patient has participated in chiropractic treatment or acupuncture. Sometimes patients feel that they didn't, physical therapy wasn't as helpful, but they really relied on those other two services. Simply need to document this as physician-directed exercise because it still does count, and there's increasing literature to support that. Certainly in the workers' compensation arena, they rely on these measures to be part of the conservative management protocol. If they're taking medications, make sure to include that. In particular, include anti-inflammatories. And surgical history. So oftentimes I think surgical history is glossed over. You might simply just say the patient's had prior spine surgery and the kind of surgery they've had. But I like to spend a little bit of time on this. I talk about the indications for surgery from the patient's perspective. Why did they have surgery? Where was it done? Who did it? What was the date of surgery in case you need to go and get the operative report or your assistant does. And then I always talk about the effect. So did the patient find that the surgery was successful, and what did it help with? This is also important to document, if they have any residual effects from the surgery. Let's say they've got a chronic radiculopathy, then you need to include that in the discussion as far as their expectations for outcomes. In addition, if you've documented their surgical history, and let's say the patient decided not to pursue revision surgery at the time of their first visit, but they come back 6 months later, it saves you a lot of time in having to research that component of their history again. As far as key descriptors, talk about ambulatory distance if they're limited, and how that relates to their symptoms of neurogenic claudication. If they do have weakness or debilitation, and in particular if it's been progressive, make sure to use that terminology. That's a sort of a flag for the insurance companies to move in the direction of authorizing your request if it's been progressive. If they have myelopathy, don't simply state that they have myelopathy. Describe how they're impaired from a balance standpoint and from a fine motor coordination standpoint. You can use different screening questions like difficulty with dropping objects or buttoning shirts, a decline in penmanship, that sort of thing. If they have deformity, again, describe the deformity in the patient's own words or sort of an assessment of what they feel and how it impacts their activities of daily living. If they have dysfunction as a result of the deformity or from, it doesn't have to be deformity. If it's, pain or a radiculopathy, talk about how they're experiencing dysfunction. And always, as we know, remember to cover bowel and bladder incontinence where appropriate. From the exam standpoint, I begin with looking at their gait and describing it. I talk about their standing visual inspection and pertinent positives. This is especially important with respect to deformity surgery and looking at their sagittal balance and even their coronal balance. From an exam standpoint, we're all used to doing a seated examination and covering their strength, sensation, reflexes, but I also try to include a dynamic strength testing component where appropriate and depending on the muscle group. So, if I'm interested in dynamic weakness of the gastrocsoleus complex, I might have them do a single leg heel raise test and compare it to the contralateral side to see if there's any obvious weakness. You can also have them walk on their tiptoes or heels or perform a single leg squat if they're able to, if they're young and functional enough to do that. Always include provocative examinations, straight leg raise, and Faber sign for sacroiliac joint dysfunction. Interestingly, in talking to some peer reviewers, they indicated that the straight leg raise test by itself is not alone. There needs to be particular documentation with respect to radiculopathy and dermatomal distribution. As far as range of motion, assess it and then document it. But also include, if they're limited, what are the reasons why they're limited? For example, if their extension was limited to 10 degrees, were they limited by pain? Were they limited by dysfunction? Are they listed over to one side and therefore can't rotate to the other? That sort of thing. As far as billing or coding appropriately for your billing for in-office visits, sometimes you need to include the lymphatic and vascular system, so mention of lymphadenopathy and whether or not it's present, and an assessment of their pulses. In the assessment section, I like to make this section pretty comprehensive. So I sort of view this section as where I'm going to use my key terms and take the role of the reviewer. So you can think in terms of ICD-10 code, so lumbar radiculopathy, M5 4.16, lumbar spinal stenosis, M4 8.06. If you think about these codes that you use in your operative report, you can try to also include them in the assessment section because that's what the reviewer may be looking for. This is an example. So if I had just documented there was a 48-year-old patient with back pain and leg pain, That's not very comprehensive, and that's likely going to be glossed over. On the other hand, if I indicated that they had low back pain, left leg pain in the nerve distribution specifically, and then I talked about how they had a disc herniation, its location, and the fact that it's impinging upon the traversing nerve root as well as displacing the thecal sac, and they have some degeneration at that level, I've been comprehensive. And then the bonus or the kicker is to say, well, they also have a neurologic deficit affecting the gastrocsoas complex. It's both static and dynamic, and explain the exam finding that went with it, as well as the lack of a reflex and a positive straight leg raise test. Now the reviewer can simply go to my assessment section, which is oftentimes what they do, and they see number 5 and they say, okay, this is very straightforward. And then they can authorize it. And on your end, it saves you time. You don't have to do a peer-to-peer call. You don't have to get frustrated or aggravated by that disrupting your practice or your surgeries. And then finally, the plan. So I always describe what was done. If I reviewed their clinical history, their physical exam findings, and their imaging findings with them, I say that. I talk about the conservative management that is appropriate for this situation. It's good to do that because it reminds yourself that you've done that when you're doing the peer-to-peer call, and it also is just good practice. I then discuss the operative management where it's appropriate, and I do. If I recommend surgery, I mention the procedure by title. I talk about why they're a candidate for that surgery, and then the details of the operation. What approach am I going to take? How many levels are going to be included? Whether or not I'm going to include an interbody, and whether I plan for inpatient or outpatient. That really helps those people seeking authorization for you, your schedulers, or in particular with work comp, they want to include those things because they want that authorization up front. If there are major risks involved, then I also use this opportunity in the plan to document this, thinking from a liability perspective. So, we're all familiar with the opioid crisis. If you expect to give them post-operative pain medications, indicate this and say that you talk to the patient about potential addictive consequences. I think about my approach. So if I'm doing an anterior approach to lumbar spine, I mentioned the vascular issues, the use of an approach surgeon where appropriate, and if I'm working with a male at a lower level, think about sterility, retrograde ejaculation. And once you start doing this on a regular basis, it reminds you to actually mention that to the patient. You should be doing that as well. If they're a young patient, I've recommended fusion to them, certainly mention the risks of adjacent segment disease. And if they come to me with a neurologic deficit and I'm recommending surgery to them, this is where I make sure to say, well, there may be some chance of permanent deficit because they've already had some degree of nerve damage. So that's your opportunity to highlight these issues. As far as documentation for surgery after surgery, in the operative report, I do list the ICD-10 codes where appropriate, and also in the procedure where I outline the specific procedures, I list the CPT codes. I think what the boards are looking for in your operative reports is to ensure that you perform a surgical timeout. You want to mention the correct patient, the correct procedure, and laterality where it applies. This is also your opportunity in the operative report to document complexity. So if you anticipate this is going to be a complex surgery, in the indication section, mention why it's complex. And then the surgical findings sort of bolster your claims that this is in fact a complex procedure, indicate where you spent more time, more effort. And when the biller in your office goes to obtain reimbursement, that's going to help support your coding. And oftentimes I will draw their attention to that when I give them the operative report. So, as far as coding for procedures, this tends to be sort of a number soup. It's a bit intimidating at first glance, but I think that coding in particular is very straightforward and it is repetitive. You do the same type of procedure quite often, and so you become accustomed to it. Typically within a multi-specialty group, you'll have an in-office biller who's specialty specific, so they're billing not only for you, but your other partners that do the same type of surgeries. So rely on them to see what kind of examples they've seen. I sort of go through this process where I ensured initially that the coding I'm using is correct from their perspective. And then I looked at if they have any other suggestions. And then finally on the back end, I went back and said, okay, show me what kind of reimbursement I'm obtaining per code so that I understand where I need to make corrections or where I need to further support myself in the operative report. Because most of us use templates for our operative reports. And then sometimes you're missing out on necessary items that will help the biller. You may wish to cross-reference your pre-auth. So in the pre-authorization that your scheduler submitted to the insurance company, they asked for authorization for certain codes. If you're going to, make sure you include those, but if you're going to add additional codes, also, again, ensure that your documentation reflects that. We talked about considering complexity. Consider your payer. So in particular for Medicare, if routinely you're coding for complexity and adding a modifier, Medicare is going to pay attention to this. So, there's a track record of this. So just be mindful of that. Doesn't mean that you shouldn't use the complexity factor, especially if you are doing complex cases, but just be mindful. As far as your resources for finding the correct CPT codes, there are several of these. The two sort of booklets on your left are comprehensive, and really you can find any code you need and the description for it. Some companies will put out their own reimbursement guides and sort of delineate which codes are necessary by procedure, so that's very helpful. NASS itself also has common coding scenarios. Say you're doing a complex corpectomy and you want to look at what are the types of codes you can use, depending on whether or not you use an expandable cage versus an allograft that can help you. Coding CPT codes are really at your fingertips at this point. You can use Google, or you can look on your phone. There are applications that AAOS provides, Codex Lite, where you can search the terms. Oftentimes your EMR, when you build your surgery template before surgery, allows you to look up code, so that builds familiarity as well. And then finally, utilize your colleagues. So your senior partners have done this for a long time, and they're well versed and skilled at identifying the correct codes and allowing for the appropriate reimbursement for the procedure you're performing. So don't hesitate to talk to them. So in this final section, I'm just going to kind of go through some common procedures to introduce the codes to you. We're going to start with the simplest of some surgery. So microdecompression, straightforward surgery. For example, left-sided L5-S1 microdiscectomy, single side, single level. So for that, you'd use 63030. That's a unilateral single level surgery. If you use the microscope, you can bill for this. The reimbursement is certainly much less than the primary procedure, but everything counts. If you performed a bilateral L5-S1 microdiscectomy or microdecompression, then you would add the 50 modifier to that first code. If you did an additional level, you can use the 63035 and then times how many ever levels you did that. So the first level, let's say you did a 3-level microdecompression on the same side. The first level gets 63030. The second 2 levels get 63035 times 2. If you're doing a revision procedure for that individual level, it's 63042. Often we'll have to address a far lateral disc herniation or extraforaminal disc protrusion. So that's called a far lateral microdiscectomy. Specific code for this, different from the one we just discussed, 63056. And interestingly, it's described as a transpedicular approach, working right around the pedicle. So just keep that in mind. So you can use that code separately. It does reimburse differently. If you're doing a standard midline lumbar decompression with laminectomy, the first level is coded at 63047. Any additional level would be 63048. So for example, let's say you did a L3 to S1 decompression and you remove the L5, 4, and 3 lamina. L5 lamina would be 63047. The additional 2 levels, as you see there, would be 63048 times 2. Again, if you feel there's complexity in this decompression, let's say there was adherent ligamentum flavum to the underlying fecal sac that required a tedious dissection. There was severe lateral recess stenosis in which you had to piecemeal take down the facet joint with the use of the burr and Kerrisons on an interval process. Or maybe you had to leave an island of bone because it was too stuck down and you had to work around it in order to adequately free up the fecal sac and the exiting nerve roots. You can add things like the modifier, the 22, and again, describe this in your operative report. For revision of a lumbar decompression, it's the same code as it was for a microdecompression, so 63042. The only difference for a thoracic decompression is the primary code is different. As opposed to 47, you'd use 46, but every additional level, again, is the 48 code. For fusion procedures, essentially think about the concept of a fusion. You're putting in instrumentation such as pedicle screws, but also laying down bone graft in the posterolateral fusion bed. So the arthrodesis or grafting portion of that is coded separate from the instrumentation. For a single level arthrodesis, that's 22612. For every additional level, 22614. For single level of pedicle instrumentation, also called non-segmental, 22840. For additional levels up to 6 segments, 22842. And there's additional codes if you go beyond that, say in a deformity surgery. For thoracic fusion, the only difference is that first level of bone grafting is going to be 22610. Every other code sort of parallels that of a lumbar fusion. What about if you're performing, for example, a TLIF or an interbody fusion from a posterior approach? Well, that coding has changed over time, so be careful at the resource you're looking at, make sure it's up to date. For the process of decompressing or entering the canal, say, for example, a laminotomy or even a laminectomy, performing the discectomy, placing the cage, and putting the bone graft at that level, that's all bundled together as 22633. If you do a second level TLIF, that's 22634. Let's say there's a situation where you did a 2-level fusion, but you only put an interbody in at 1 level. Well, the interbody arthrodesis gets coded into the 22633, but the additional level arthrodesis can be separately coded as 22614. What about the setting where you did, let's say a patient had instability at 4-5 with severe canal stenosis, and so you had to decompress the central canal, but also put in an interbody via a TLIF approach. Then you can also add in, where if you feel it's appropriate, a 63047, that's the laminectomy code, but add on the 5-9 modifier. And that basically indicates you had to do a separate procedure to address the severe canal stenosis. And then it was separate work, once you'd done that, to be able to access the disc space, do the discectomy, and place the cage as well as the graft in the posterolateral fusion bed. Another common procedure is either a lateral interbody fusion or an ALIF, anterior lumbar interbody fusion. And these are coded relatively similarly because the concept is you're working in the anterior aspect of the disc space. So removal of the disc and placement of the cage, but not the cage itself, so just the access, the approach, and the fusion across the inner space is coded as 22558. If you do a separate level, this numerical scheme is a little off, but it's 22585. If you place a cage at that level, 22853, that represents the cage itself. If you did a 2-level lateral interbody fusion, let's say, or an ALIF, then the second level, you can't use the same 22853, you have to add the 5-9 modifier. If you used some type of allograft within the chambers of the cage, 20930, and particularly when you're doing an ALIF, oftentimes some will plate in addition to placing the cage and screws through the plate. That's all bundled into 22845. That coding may be going away in the near future. If you applied a plate from the lateral aspect, you can also use 22845. Depending on the number of levels that you plate, you can use these varying codes of 22846 or 22847. The additional consideration is that if you performed a standalone ALIF, let's say, and you put the screws through the cage itself, oftentimes that's the way that the jig is manufactured, or the design of the device, then you cannot add the 22845 for separate plating. And that's some of the reason why the coding may be going away for that aspect. If you're doing the same lateral or anterior fusion, interbody fusion in the thoracic spine, the only difference is that initial code, which is 22556 as opposed to 22558. And we've touched on this a little bit, but there are specific grafting codes. Now, again, these do not reimburse as high as the primary procedures, but they're important to include. So if you use local autograft, for example, you took this from a laminectomy and morselized this, that's 20936. If you took a structural autograft, say from the iliac crest, that's 20938. If you used morselized allograft, for example, crushed cancellous bone, that's 20930. If you took a structural allograft, for example, if you use an allograft in the cervical spine for ACDF, that's 20931. And if you aspirated bone marrow, say from the pelvis, and then spun it down and put it onto a carrier, that is bundled as 20939. So we've touched a bit on the peer-to-peer process. This is where essentially another physician will call you and try to review your case with you to ensure that it's appropriate to authorize or not. I mentioned that it can be frustrating and aggravating, and oftentimes you have to ask that reviewer, what their specialty is to make sure you guys are speaking the same language. But I find that early on in your practice, you can really utilize this process to understand what codes are necessary to achieve what you hope to bill for, and to adequately represent the procedure you're going to do. So rely on that conversation. It can be a friendly and cordial, collegial conversation. Rely on that reviewer for the codes that they think that are appropriate for this process. And if they don't think it's appropriate, whether it's coding or the procedure that you've asked for, and get their perspective on why they don't think it's appropriate, as opposed to being confrontational in that process. And there are some insurance companies which will authorize certain codes versus others will not, and try to understand the rationale for that. Oftentimes, when you talk to the medical director of that insurance company, they're willing to review literature if you send it over to them, especially if it's peer-reviewed literature, and they may change their mind because of that. So don't forget that option. So in summary, make sure that you're thorough in your documentation. I think that really can aid your decision-making process, and in particular, streamline your workflow in your office. Familiarize yourself with common coding procedures. Don't hesitate to go back to the slides we just discussed, and then start practicing using those codes in training, and run them by your attendings or mentors to make sure that you're doing this correctly. It's kind of the process or aspect of training that we don't tend to rely on as much, and then you're out in practice and you're sort of faced with the reality that you want to make sure that you're coding accurately to be reimbursed appropriately. And make sure to utilize multiple resources for coding. Don't just rely on one. Don't get stuck in a repetitive pattern, because you may be missing out on potential reimbursement. Thank you.